I speak fast normally, I'll speak faster. Essentially, it's important when we talk about stents as a whole to remember why we had stents in the first place. It was to prevent dissections from happening, to scaffold the artery after the standard plain balloon angioplasty. Now, one of the problems with this, though, when we started putting in stents is that restenosis was an issue. And as a result, you needed to maintain the mechanical properties of stenting, but have a drug to prevent the restenosis or scar tissue formation that occurred after you put stents in. And so as a result, drug-eluting stents were invented. They maintained that characteristic, but you had to get the drug to the vessel wall somehow, and not just with rapid burst kinetics, but to kind of leave it there in a sustained way. And in general, that requires a drug carrier vehicle or a polymer. Now, we do also know that while drug-eluting stents were incredible devices when they first came out, there were amazing results seen. There were also some bad outcomes associated with them, largely due to inflammation and late vascular responses to this. We see from studies like the Syntax trial, multivessel disease trial, that at 5 years among patients with multivessel disease treated with the Taxus drug-eluting stent, there was a 10.4% rate of stent thrombosis, which is clearly too high to be treating these patients safely with these devices. Now, in terms of when these bad events occur, there are some events that can occur early within the first 30 days, and that can be largely due to procedural issues or other mechanical properties of the stent. But some of the later events that occur may be relating to polymeric effects or other properties of the stent that cause late inflammation. Now, this has been shown in studies that looked, for instance, at fluoropassivation with the durable polymer seen in the everolimus-eluting stent family compared to non-coated stents that perhaps has less thrombogenicity, and that's compounded by the fact that you can reduce thrombogenicity by reducing the thickness of struts, which we've seen an evolution of over time. So if you look at the outcomes with this current generation of durable polymer stents, it's great. I'm not going to go through the data in detail other than to tell you that first, it's superior to the first generation of stents that we had, and second, they tend to be largely comparable across the stent platforms that are seen. These are data from the Spirit experience with the Xience everolimus-eluting stent, and these are outcomes with Resolute all-comers comparing zotorolimus-eluting stents to the Xience stent, showing essentially superimposable Kaplan-Meier curves over time. But one of the issues that can occur is there's still a late accrual of events at approximately 2% per year, irrespective of what stent type is seen. And so while our devices right now are amazing, there still are these late events from occurring. And so the question is, can we perhaps improve upon the current outcomes that we see? There's three sort of ways that you could approach this. The first would be to just have a metallic DES and get rid of the polymer altogether. You can also have bioabsorbable scaffolds, and Alex is going to talk about that. And then the third area that I'm going to be talking about a little bit is metallic DES, but you take the polymer and have the polymer go away over time. You deliver the drug for the period you need it, and then the polymer goes away. So there's data on several families of these. The Biometric Stent is perhaps one of the first ones that came out. This had an abluminal polymer, so the polymer is not on the side that abuts the vessel. The lumen is actually abuts the vessel wall and elutes Biolemus A9. And what was actually shown in studies of this stent compared to first generation durable polymer stents is two things. First is that the absolute rates of late events such as stent thrombosis are lower, but there's also this flattening of effect. And you can see my mouse. There's sort of a flat effect, especially out beyond a year. And so this is some hypothesis generating data that suggests that by having a polymer that goes away, particularly in comparison to first generation drug-eluting stents, you can make these devices perhaps more safe. This stent has been studied in multiple studies, also a STEMI study that showed a reduction in terms of adverse events out to a year compared to a bare metal stent comparator. Now, there are other stents that are under investigation. You'll see data from this stent presented in the next year or so. This is the Osario stent compared to Xience Prime, showing largely similar events to 24 months, but larger randomized trials are going to be coming with this stent, as well as this stent, the Dissolve 2 stent, another type of bioabsorbable polymer stent. And one of the things I'll come back to in a couple minutes is the fact that many people try to look at all bioabsorbable polymer stents as a class and all together, and all of these stents have different metallic backbones, different polymers, different elution kinetics, and I think we have to resist the temptation to do that. The one that many of you are familiar with because it's approved here in the United States is the Synergy stent. This is a platinum chromium thin strutted stent with a PGLA polymer and everolimus that gets eluted abluminally from a thin coat. This is sort of the release kinetics of this device in particular, where you see that the polymer remains only 30 days after the drug, and basically you sort of minimize the overall concentration of polymer delivery. Now, and drug delivery. If you look at the randomized data of this stent compared to a non-bioabsorbable polymer comparator stent, the outcomes appear to be very, very similar with respect to outcomes out to 2 years now shown in this EVOLVE-2 randomized trial. But if you look at sort of the pooled experience, and this is still early because we need more data, it does appear that late thrombotic events beyond 30 days are very rare. And so if this is corroborated with longer-term follow-up in larger series of patients, then this promise of a safer stent over time will actually become realized. Fortunately, many of these trials are going on right now. This is the program of these trials. We're actually involved in one of them, the short depth trial, which is not a trial per se, it's an observational study, but looking to see, because of this, can you leverage that to reduce your duration of mandatory dual antiplatelet therapy? And so this is actively enrolling. Now, one aspect that we will just bring up in the last few minutes is this desire to compare stent platforms and use bioabsorbable polymer stents as a class. This was very nicely shown by our Chinese colleagues, Zhubo and others, where they looked at two very similar stents. One was bioabsorbable polymer, the other one actually was also bioabsorbable polymer, but a different stent platform. And what they showed in this trial is that there were different rates of events in a very large trial, 2,000 plus patients, out to a year. So I think that one of the critical aspects of this is because one stent may not be as good or maybe better than another comparator stent, we can't pool these together. And that's shown here in this slide, where you see very, very different rates of elution and polymeric absorption across this entire family of bioabsorbable polymer stents. I would also be even hesitant to compare durable polymer stents to each other, because over time what we've basically seen is we started off here with these thick strutted stents, and now we're down here with thinner strutted stents, different types of polymer compatibility to the body, and so to compare across all these categories is very, very challenging. I'm not going to make this point about network meta-analysis due to time, other than to simply say that doing network meta-analysis and coming up with all these cross-study comparisons, in my mind, is like looking at the results of a World Cup group and saying that because one team beats another, that team beats another, that team beats another, then this team should beat that team. But in reality, and this is a real example from the World Cup last time, is that actually the opposite happened. So in my own personal opinion, network meta-analysis is something that is really purely hypothesis generating and shouldn't be touted as the predominant way we assess stents. So in conclusion, current and future directions in stenting. First, it's clear that the current generation of DES that we have are fantastic, appreciably improved both safety and efficacy across ACS and stable CAD subtypes. Bioabsorbable polymer DES may offer advantages over durable polymer DES, but are definitely not a homogeneous class of devices, so we have to look at the device-specific data very critically. And then we need appropriately sized large randomized trials to determine whether or not any or all of these devices are going to be safer or more efficacious than durable polymer DES, and those trials are ongoing at present.